On behalf of Cardiovascular Division of Intas Pharmaceuticals, I welcome you all for this edition of I-Konnect. Medicine is a field of rapid advancement and continuous innovation. More and more newer evidences are being generated daily, and accordingly, our understanding and management of human diseases needs to be updated. I-Konnect is a very unique endeavor of Intas aimed to bring the leading international faculty from various specialties related to cardiometabolic disorder onto a single platform to discuss and deliberate on recent developments and the best practices in the management of cardiometabolic disorders. Our international expert for today is none other than Dr. Christopher Warner. Dr. Warner is currently the Senior Professor of Medicine in Department of Clinical Research and Epidemiology at University Hospital. Uh, uh, University Hospital of Würzburg, Germany. He is also the visiting professor of renal medicine in the Newfield Department of Population Health Clinical Trial Service Unit, University of Oxford in UK. His key research areas include diabetic kidney disease and lipid disorders. Dr. Warner is the immediate past president of European Renal Association. He has in fact published over 1,000 articles in PubMed and has a Hirsch index of 190. He has been a part of key landmark trial like 4D study in 2005, EMPA-REG outcome trial in 2015 and 16. It is indeed my pleasure to welcome such a stalwart in the field of medicine to our platform. A very warm welcome to you, sir. Dr. Warner will be presenting his views on organ protection role of SGLT2 and its combination. Kindly request all the audience to post your questions after the presentation during the Q&A session. Now, without any further ado, I'd like to hand over the session to Dr. Warner. Over to you, sir. Thank you.
Thank you. Very kind of you. Thank you for this kind introduction. And I'm proud, or I'm really pleased that you listen to somebody outside from India who has a lot of experience since about 10 years. And I have started my life with EMPA-REG outcome, the first study. So I will give you my opinion, and I'm very pleased to hear the opinion of India and what you do differently from maybe some other parts of the world. So first of all, I have my disclosures, companies where I'm working together in clinical trials in the moment. And I start my lecture with all the SGLT2 inhibitor studies we have today, the larger ones, the outcome study. So you see on the left bottom, the EMPA-REG outcome, it's now 10 years that we are now have this study, cardiovascular outcome study, followed in green by the Canvas program, Declare and Vertis. But then we also have other studies with heart failure in the primary endpoint or the kidney in the primary endpoint. And I'm a nephrologist, and I show you also data from the kidney. Here, Credence, the first one published with canagliflozin, dapagliflozin in a larger cohort or in a similar cohort with more non-diabetic kidney disease, and EMPA kidney, the largest study with even more non-diabetic in comparison to diabetic kidney disease. If you win with the kidney, then the world is open, usually, because kidneys is difficult, but if you have good signals from the kidney, safety is important, then usually you win in the market. This is some experience, some recent years. So these trials, so many we received outcome trials in the last 10 years are different. At least the kidney outcome trials, when I'm comparing now EMPA-REG outcome, Credence, DAPA, and EMPA's kidney, they are all good SGLT2 inhibitors, excellent molecules, but they investigated different cohorts, different people with different urinary albumin creatinine ratio in blue, with different diabetes status and cardiovascular disease. EMPA-REG outcome only had diabetic with cardiovascular disease, and EMPA kidney, the latest one, had very low kidney function, but little cardiovascular disease and more non-diabetic, and therefore less albuminuria. So all these kidney trials have been stopped early because of overwhelming benefit. So I would say all are very good. Different population. We learn from each trial different things. So another change, another comparison to the Emperor, the heart failure trials, for example, dapagliflozin with the DAPA heart failure trials are showing similar things. I have here a slide now with more empagliflozin, and you look at the heart failure trials, they have the highest risk for mortality, followed closely by the kidney trials, and then similar to cardiovascular outcomes. So a very different risk in this population. And here is the meta-analysis. Here, kidney disease progression. First, I show you the diabetes trials with DECLARE, CANVAS, EMPA-REG outcome, cardiovascular. Then you have the heart failure outcome, DAPA, EMPA, and then you have below those kidney outcome trials. And here is the kidney in the secondary or primary endpoint. And you can see how beautiful it is working with the kidney. All point estimates are on the left. DAPA-CKD and EMPA-kidney are virtually identical. Large number of patients, successful treatments. And if we go to now the cardiovascular death or hospitalization for heart failure, we see in all these trials the same thing. Chronic kidney disease trials had a lower glomerular filtration rate. You see the number of patients, nearly 40,000 in cardiovascular risk. There were 10,000 in heart failure, and then 20,000 with chronic kidney disease, subtotal of 75,000 people. And it works. All these SGLT2 inhibitors work in the same manner on all these endpoints, irrespective what the underlying disease is. And it's quite impressive. It's a 30 to 40% risk reduction, and this is twice as much as we get from RASI, from ACE inhibitors. So more powerful than ACE inhibitors. Incredibly, what we got from the trials in the last years. And here is the cardiovascular death. Very consistent, not so powerful, maybe more on the kidney and heart failure, less on the cardiovascular death with a 14% relative risk reduction, but all significant point estimates to the left of unity. So this is the meta-analysis, and now go a little bit into detail and show you Kaplan-Meier survival curves. Maybe you are more familiar. The primary endpoint is a 50% decline in eGFR. End-stage kidney disease is dialysis. Cardiovascular death, and you see that the relative risk reduction is 39%. Curves are opening up at around 8 months to 12 months. You have a high p-value, and the number needed to treat is quite low. Therefore, it is a drug which is incredibly effective and for use of a large population. If you look at another endpoint, a secondary endpoint from DAPA-CKD is cardiovascular death or hospitalization for heart failure. Look at the same picture. The curves are opening up very early. After 17 days, it was significant already. The absolute risk reduction is not so high because the number of events were not so high than with kidney or cardiovascular or kidney or for example. So the percent relative risk reduction is 29%. And then we go for another all-cause mortality, and DAPA-CKD hit all-cause mortality similar to empagliflozin in the EMPA-REG outcome. So two signals for all-cause mortality with empagliflozin in cardiovascular outcomes and dapagliflozin in CKD. And this is beautiful to have all-cause mortality reduced. Let's go to EMPA-KIDNEY. It's a different trial. lower kidney function, 37 ml per minute, for example, a little bit different endpoint, but also end-stage kidney disease. The relative risk reduction was 28% because the risk was lower of these people, but also very effective, number needed to treat 28 in a lower GFR population down to 20 ml per minute, where you can start empagliflozin and don't stop until dialysis, so continue treatment. This is the kidney outcome. And I will show you from the empagliflozin trials the slope analysis. Nephrologists like slope. They look at GFR. The entire cohort, 6,600 people, started with 37 ml per minute. You see the initial dip. The dip and then the stabilization over time. Don't stop the medication when you have a dip, even up to 30% dip. It shows that the drug is effective. The drug lowers intraglomerular pressure, lowers hyperfiltration. This is single nephron hyperfiltration, and you give the kidney the better chance to survive. So the dip is good if you see this. And you can see that the placebo people, they progressed by 2.75 ml per minute per year. And within 8 years, they are on dialysis. And you can give these people 2 more years to save them from dialysis with a progression rate which is 1.37 ml per minute, much lower. So naturally, we would like to start earlier, not at 37. So why not starting at 50, 60, or 70 when people have albuminuria? And even here is the primary outcome by kidney function. So on the left-hand side, you see the categories of eGFR less than 20. Only a few people started eGFR less than 20, most between 20 and 30, 30 to 45, and above 45. But the result is very consistent. Point estimates, left of unity, it's effective by 38% or 28% in all across the board. And when I go now to something people are very interested, to the loss of kidney function in relation to albuminuria. On the right-hand side, you see more than 300 milligram per gram UACR, urinary albumin creatinine ratio, in a spot urine in the morning. And you have in this category, previously called macroalbuminuria, you have a slowing from 4.11 ml per minute per year progression down to 2.35. This is 43%. But if you go to the middle block, which is microalbuminuria, you even can reduce by 71%. So it's much more effective in lower ranges. And if you go to no albuminuria, and 2,000 patients in EMPA kidney had no albuminuria, you see a risk reduction by 88%. So this is remarkable because usually you age by 0.7 ml per minute per year. And here you reduce it to a 0.11, to a zero slope. And my question always is this an anti-aging medication, what we have in hands? But other doctors say, I have an 80-year-old lady with a glomerular filtration rate of 35, sitting at home and is happy, had no pain, and she has no albuminuria. So why treating her? She will never go in her life into dialysis. Yes, I accept this. This is right. But you have also to ask the lady, do you want to go to hospital? Because SGLT2 inhibitors reduce all-cause hospitalization. And you have also to test for heart failure, because if she has HFpEF, diastolic dysfunction, then you have another indication. Then you treat also heart failure, and many of the people with low eGFR have HFpEF. So yes, why treating? Only if you have other indications. Could be a summary here. Guidelines have taken up this beautiful data in the KDIGO, Kidney Disease Improving Global Outcomes 2022 Clinical Practice Guidelines. American Diabetes Association has taken the same message, the same way. European Society Cardiology, they all speak the same language, and they have graded these data. CKD largely does not exist on its own, but as part of the interconnectedness of the cardio-kidney metabolic multimorbidity syndrome, is one comment in the guidelines. So be an internist, be a general practitioner, please, and look at the entirety of the data, the patients, in which phase he is, what are the wishes, what do you want to preserve. Very important. So here is the KDIGO recommendation. On top is lifestyle, and I make it now a little bit bigger. I take the lifestyle away. We always do a lifestyle and show you first-line drug therapy is an SGLT2 inhibitor. You start treatment with an eGFR above 20, don't stop until dialysis. You combine it best with metformin. And you start maybe with metformin, and then you add SGLT2. Don't wait too long. A fixed combination is excellent because you save pills. You could also, in some countries, combine it with a RAS inhibitor, whether available or not. We have in Germany RAS inhibitors with statins and calcium channel blockers as a fixed combination. So every country has different fixed combinations. The next level is additional risk-based therapy. And here there is recommended a GLP-1 receptor agonist is needed to achieve individualized glycemic target. However, GLP-1 receptor agonists are expensive in some parts. So usually you need maybe something and you go to the next level and use other glucose lowering drugs if needed, for example, DPP-4 inhibitors, and combine it with because SGLT2 inhibitors, when you have a GFR of 30, are not very effective antidiabetics anymore. You don't have a lot of glucose excretion, but you have a very good organ protective treatment. And then you go to the right, all patients, when you have blood pressure, not a target, you add DPP-4 inhibitor or a calcium channel, a calcium channel blocker or a diuretic. So the question is, people have eventually take a lot of drugs, and this is an issue always in our outpatient clinics. So to achieve glycemic targets and to achieve blood pressure targets is something what requires combination therapy. And to avoid the many tablets, combination therapy are good for compliance. I give you an example. I have a 60-year-old male, type 2 diabetes, GFR, and the problem here is very high urinary albumin-creatinine ratio. He is progressing with 7 ml per minute per year to dialysis. He came from a general practitioner and had blood pressure, BMI, LDL cholesterol. Some people would say, oh, this is not so bad when you look at the tablets. So he's receiving standard of care with ACE inhibitor, a calcium channel blocker, a statin, aspirin. I do not know why aspirin, because he has no cardiovascular disease. Metformin and the DPP-4 inhibitor, and I was asked, is this patient appropriate for SGLT2 inhibitor? I would say, yes, bring this albuminuria down. The other doctors ask, still suboptimal. Blood pressure, he could, LDL lowering is necessary. I said, no, start SGLT2 inhibitor now. And I gave him 10 milligram per day. He also is a non-smoker. He was never successful with lifestyle. He had dyspnea when doing a flight of stairs, so maybe he has some heart failure. SGLT2 inhibitor is good. And he told me, doctor, I take already 7 pills per day and I don't want more. So again, something for combination therapy. So fixed dose combination is today recommended by guidelines, and we have a lot of data. For example, here an SGLT2 inhibitor with a DPP4 inhibitor, linagliptin or sitagliptin have the most data. Linagliptin has actually 2 studies. I will show them. And this combination may be preferred over other conventional therapies because they are safe and tolerant and well tolerated. And I told you SGLT2 inhibitors are not very good with GFR of 30, 40, 50. You need something else. You need the DPP4 inhibitor. Also, they have no cardiovascular protection. With proven benefits, with proven safety. This is what in guidelines is written. Fixed drug combinations have usually better hemoglobin A1C reduction. Here, a trial with limited number of people, but shows you empagliflozin in combination with linagliptin, 10 milligram or 25 milligram in combination with 5 milligram, has a potent hemoglobin A1C reduction of left-hand side 1.2, 1.1, or 1.9. And when you do a combination of other SGLT2 inhibitors, for example, ertugliflozin, which we do not have in Germany, but sitagliptin, reduce the dose when you proceed with glomerular filtration rate lowering. But in essence, in normal kidney function, they are equivalent and comparable with the same effectiveness. Here is the Carmelina and the Carolina study in about 6,500 patients, the Carmelina and the Carolina in 6,000 with Carmelina has a lot of kidney patients. And it was not effective in reducing cardiovascular outcomes when we look at 3-point MACE, but it has no safety problem with hospitalization for heart failure, such as other DPP4 inhibitors. One has heart failure signal. Carolina, earlier patients with normal kidney function, same thing, very safe drug. So a lot of data out there and a perfect DPP4 inhibitor for lowering hemoglobin A1C. However, before the treatment, I always say to my students, there should be a diagnosis. Excuse me. There is the KDIGO heat map. On the left-hand side, you see eGFR. On top, you see albuminuria. Everybody is doing eGFR, and when you look down to an eGFR of 50, 30 ml per minute, I can talk to my patients and say, you have 50% kidney function. And patient understand this. But nobody's doing albuminuria. And you can see the higher the albuminuria from A2 microalbuminuria to A3 macroalbuminuria, the progression rate and the cardiovascular death is much higher when you have high albuminuria. Albuminuria is an independent prognostic parameter for GFR decline and cardiovascular death. However, if you have a glomerular filtration rate above 60, that's normal. You cannot detect kidney function decline or the risk of diabetes for the kidney. You cannot detect diabetic kidney disease when you do not test albuminuria. This box is necessary in people with normal kidney function. When they have high albuminuria, they are on the risk slope to develop cardiovascular disease. The cardiologists know this, and they do start now testing albuminuria. When you have an eGFR of about 60, you know that the patient is at this position in this part of his life. More you do not know. You have to test multiple times eGFR to get a slope. But when you test once UACR with 800 milligram, such as my patients, you know that the patient has a high speed towards the cliff, and the cliff is dialysis. So with UACR, you have a feeling about progression. eGFR, you know only where the patient is in the moment in his life. We nephrologists, we like to see slopes, and we have here the principle of treatments. The slopes, this is 20 years old. It was a type 1 diabetic. When he had normal kidney function, he progressed then with 5 ml per minute per year. And what we want to bring this curve up that the patients never will go into dialysis. But usually nephrologists, they see the patients only when he has GFR below 30. So actually we need to work together. Most patients are in the hand of general practitioners. So general practitioners are important to prescribe SGLT2 inhibitors together with all the specialists and nephrologists to bring these drugs to the patient. You can do more when you prescribe earlier than in the later stage. So some practical consideration and summary. High-risk patients require an annual screening for eGFR and UACR guideline, A1 grading. Individuals can be identified who carry a risk for CKD progression and cardiovascular risk. The early treatment to maintain kidney health using SGLT2 inhibitors is a good strategy under development. Early treatment is still under development because not yet adopted, especially in the elderly. 10 years after EMPA-REG outcome, the SGLT2 inhibitors became standard of care in diabetic individuals with cardiokidney metabolic comorbidities. So the SGLT2 inhibition is a CKD, a heart failure, and a cardiovascular disease treatment, is not an anti-diabetic, or is not only. Fixed dose combinations are useful to maintain compliance when pill burden is high, and diabetic people who have an indication for RASI also always have an indication for SGLT2 inhibitor. No major safety issues have emerged in randomized controlled trials and real-world studies, making SGLT2 inhibitors appropriate for use in a broad population at risk. So I think I am coming to the end, and I thank you for listening to me. Thank you very much.
Thank you, Dr. Warner, for that elaborate and as well as an enlightening presentation regarding organ protection benefits of various SGLT2 inhibitors along with its combination with DPP4 inhibitors. I think we have already received a couple of questions from the audience. So let me take, so depending upon the time availability, we'll take up all the questions that we get from the audience. So my
Yes,
first
please.
question, yeah, my first question to you would be that what is exactly the possible mechanism of action of SGLT2 in terms of CV and kidney protection? I mean, the basic mechanism we all know, the SGLT2 inhibition leading to reduction in urinary excretion, but what is the possible mechanism for CV and the kidney protection is the first question.
So several. First of all, it lowers intraglomerular pressure and hyperfiltration. And this brings the kidney into a better metabolic and energetic place. And via the renal nerves, this is transferred to the cardiovascular system. And similarly, the hemoglobin is going up, hematocrit is increasing, more oxygen transporters are going into the circulation and leading to a better supply for the heart. So these are the main mechanisms, and many other have been proposed. But I think I stay with volume reduction, better cardiovascular volume reduction also by, but this is what you told us, by glucose excretion. Yes, thank you.
Thank you, Dr. Vaughan. Question is particularly related to empagliflozin. So apart from, we all know SGLT2 inhibitors basically is the urinary excretion leading to somewhat of fluid loss. So apart from this, I mean, what could possible mechanism for also, as along with that, I think we also know that because of the glycosuric effect, there is loss of calorie also. So what could be the possible mechanism for weight reduction with the SGLT2 inhibitors, which we see in many of the trials? In EMPA trial, I think we can see somewhere between 3 to 5 kilos of loss. So what could be all the possible mechanism for that weight loss?
There is a very attractive hypothesis. Whenever an organism is losing calories, you mimic starvation. Yeah? And we know that diets or calorie restriction and starvation is causing longevity or bringing the organism in a better survival position. And there are very attractive data, meanwhile, that intermittent fasting, yeah, or 16 hours fasting are similar effective. Yeah. And therefore, I'm convinced that this loss of calories until you have reached another level, stabilization, loss of calories, mimic starvation is a very potent protective mechanism.
Thank you, Dr. Warner. So next is a very interesting question. So this is somewhat related to insulin resistance. So is there any effect of, I mean, empagliflozin or overall SGLT2 inhibitors on insulin resistance? Any kind of evidence regarding that?
Uh, we have some post hoc analysis of EMPA-REG outcome, and others also have this with dapagliflozin. You reduce the amount of insulin necessary when you provide SGLT2 inhibitors. So that was a very critical point at the beginning, because you do not want to reduce insulin to avoid diabetic ketoacidosis. But automatically, less insulin is necessary, and doctors see this and reduce the amount of insulin. So insulin resistance apparently becomes a little bit better. We tested this with HOMA index and have some indirect measurements, and also these data say the same, that insulin resistance is improved. Yeah.
Yeah. So I think even, I mean, I also wanted to ask this question. We have received a similar question from the audience. So there are many meta-analysis. I think couple of meta-analysis which says that when you're adding DPP4 inhibitor to an SGLT2 inhibitor, somewhat, I mean, it reduces the risk of genitourinary tract infections, which are pretty common when SGLT2 inhibitors are prescribed alone. So have you seen such kind of difference, I mean, in your clinical practice when combination is used rather than a monotherapy with SGLT2 inhibitors, sir?
No, I have not seen this. I do not prescribe this actively on top of to avoid this. We have no good data from large outcome trials. These
Mm,
data are coming from small groups.
mm.
Actually, you cannot. I'm not convinced that these are good data. On the other hand, it does not cause harm. So if you believe this, you can use this combination. But I think that this is, I don't think that's very helpful.
Okay, thank you, sir. Uh, yeah, just let me look at the other question. How often do you observe transient EGFR reduction? How much time does it take to resolve, sir? So you also brought that up in your presentation. There is a dip initially when SGLT2 inhibitors are given. So, I mean, how long that dip exists, and how much time does it take to recover back to normal, sir, normally?
So I get a dip usually in a third of my people. 3 out of 10 produce a dip, and sometimes quite substantially. Yeah, so 20 ml, for example, when you start with 50 ml. So that's quite substantial. I stay calm. I measure after 3 months. Yeah, I do not measure after 2 weeks. I don't control this anymore. I just treat. And after 3 months, usually I do not see this anymore. What I told you is when you measure often, you can see this. But after 3 months, they are back to the same level or remain some 5% below their original ones. But the dip happens tomorrow, 1 day later, and then slowly comes up over time, usually after a year in the large empiric outcome trials, we have seen the stabilization after 1 year, but you can see it also earlier. About a third of the people have this dip.
Sure, sir. Thank you. I think next question was anticipated as we both now we need in our country we have now both generic formulation of dapagliflozin as well as empagliflozin. So, are there any head-to-head trial, particularly between these two molecules regarding kidney and CV protection, or I mean, can we anticipate such kind of evidence in the future?
Since now we don't have head-to-head trials, I do not think that we get them in the future because the molecules are now coming also in the Western world out of patent in the short future, so nobody will compare them. But if you compare the large outcome data, you can
Mm.
see that they are quite comparable. Yeah, they are very good medication. And if you are a friend of dapagliflozin, you can prescribe dapagliflozin. If you think that the patient is with his glomerular filtration rate low, then you use empagliflozin because empagliflozin has convincing data with low GFRs. So overall, I don't give a preference to the one over the other.
Sure, sir. Thank you. So particularly next question is regarding use of SGLT2 inhibitors in diastolic dysfunction. So probably HFrEF patients. Sorry, HFrEF patients. So do you start SGLT2 inhibitors in grade 1 diastolic dysfunction? This is one of the questions that we received from the audience.
Yeah, grade 1 is difficult usually to diagnose. You need an echo. You can ask the patient whether he has breathing problems. Um, Meanwhile, I start this organ protective treatment quite early. Yeah, because why waiting until the situation gets worse? And beside these early stages of of HFpEF, for example, you can very often also see that slowly the glomerular filtration rate declines, but you can see it only when you measure quite often the GFR. But nobody does this. So, and when you wait about a half a year and you think, should I do, then the patient already progresses. So when I see early signs of albuminuria, HFpEF, then I usually I start treatment. I have now 10 years of experience and I oversee this time, and we are now more and more relaxed because we handle these SGLT2 inhibitors. They are so powerful and they become standard of treatment in for early treatment.
Sure, sir. Thank you. So there are a lot of other interesting questions also. So particularly the next question is related to non-diabetic chronic kidney disease. I think the audience wants to ask patients, particularly hypertensive kidney disease patients. So, is there any role of SGLT2 there, sir, particularly non-diabetic CKD related to hypertensive patient, chronic hypertensive patients?
Yeah, today we had only the type 2 diabetes, but a very good question for non-diabetic people because in the EMPA kidney outcome trial, there were 3,000 people with non-diabetic kidney disease and 1,200 with hypertension-induced sclerosis of the kidney. The SGLT2 inhibitor is not a powerful antihypertensive medication. It only lowers by 2 millimeter mercury, but it causes the same protection for the kidney. It lowers albuminuria when there is some. It normalizes intraglomerular hemodynamics, and it is a powerful reduction in outcomes, such as cardiovascular outcomes. So yes, I would compare. Actually, you have the label today. You have the indication and the Food and Drug Administration, the European regulatory authorities have given the label. It's a CKD treatment. It's not only a treatment for for diabetic kidney disease. Very
Thank you.
important. Thank you for this question.
Thank you, sir. So the next question is particularly, I mean, based on the evidences, what generally we believe is that SGLT2 is particularly really effective in patients with heart failure, and GLP-1 RA can be considered based on the evidence as particularly in patients with established atherosclerotic cardiovascular disease. So, what do the evidence say, and what is your belief, particularly in terms of role of SGLT2 in established atherosclerotic cardiovascular disease? Or yeah,
Um, I see that the GLP-1 receptor agonist, when I look through the trials, yeah, I see that is a better cardiovascular protective trial than the SGLT2 inhibitor. We have seen the empiric outcome trial, which were very powerful. Later data with DAPA, Declare, TIMI study were not in earlier stages, were not so powerful. So little bit inconsistent results in terms of different cohorts investigated, but they are cardiovascular protective, but not as powerful as the GLP-1 receptor agonists. So I see them for cardiovascular disease on a higher value. However, they are so expensive in countries like Germany or the United States, even more. And therefore, I would say um, do best what is available in your country and use SGLT2 inhibitors. Some protection is always given. Thank you.
thank you, sir. Thank you. So this next is a really interesting question, particularly related to the liver benefit, I guess. So what is its role, SGLT2? Maybe I think we have a few evidences also, particularly its role in what we now call it as metabolic associated steatotic liver disease, MASLD, which was previously called as NAFLD. And also audience wants to, I mean, doctor wants to ask that are we overlooking the liver, particularly the beneficial effect in MASLD patients?
Yeah, I have seen studies with 800 patients with MASH and muscle D. Uh, there is a trend towards improvement, but it was not very powerful and significant. Therefore, you reduce calories, you have glucosuria, and you reduce a bit of the liver fat. Yeah, but it's close with 800 people. It was not significant. And now the GLP-1 receptor agonist data are ongoing with muscle D. And what I see, maybe GLP-1 is a little bit more powerful, but so far, no one of these both treatments are approved by the regulatory agencies. Yeah. So all over, we have no treatment for MASH and muscle D, but there is some glimpse that they work a little bit. Yeah.
Thank you, sir. Thank you. I think since you have quite a good nephrology practice also, so this question is particularly regarding in patients with EGFR less than 35. So is there any head-to-head comparison between EMPA versus DAPA and in real-time clinical practice, sir, in such scenarios, which would be your preferred molecule with EGFR less than 35?
No head-to-head comparison. The DAPA CKD trial included patients with GFR above 25, have a relatively small group. EMPA-KIDNEY included people with GFR of 20, a relatively large group with 2,000 patients. So I would say we are now doing the renal life cycle trial in people with in people with glomerular filtration rate below 20 and dapagliflozin, because I think that dapagliflozin also works in the low stages similar to empagliflozin. We are doing this study. We have now included 500 people. However, I see that if you go very, very low, you need to be a good doctor. Let's say a good doctor. You need to stay cool because patients experience every day something different. They have an increase in blood pressure, they have pruritus, pruritus, uremic, they have higher potassium, also SGLT2 protect from high potassium, but it's difficult to treat these people. So I have done a number of included people in the renal life cycle trial below 20. So you asked me below 35. I think we have sufficient data. Just start treatment and don't measure. Go on. It's protective. Don't measure GFR too often.
Thank you, sir. Uh,
Because can I add?
yes, sir.
Because if you add another measurement of glomerular filtration rate after 2 weeks or after 1 month or after um, the patient knows their values when they have low EGFR because somebody told them you go into dialysis. And when you have a patient with a GFR of 25 and he has a dip down to 20, then general practitioners or the patient will stop the medication because he said this drug will kill my kidney. And this is, I think, is the most often challenge we have, that people stop the medication when you have low EGFR when you start newly.
Thank you, sir. Thank you. Sir, in your clinical practice, how frequent is SGLT2 inhibitors associated, I mean, urinary tract infection? And if patient is having recurrent urinary tract infection, sir, so how do you manage such case where you need absolutely need SGLT2 inhibitors also for the overall, I mean, nephro and cardioprotective role?
So you ask me about urinary tract infection and
Yeah.
not genital infection.
Or
Yeah, I
basically
distinguish this.
genitourinary tract infection, so you can say.
Yeah. So genital infections never happen with non-diabetic people. They only happen with diabetic people.
Mm.
Uh, and it is about, it becomes lower and lower over the years when I talk to the patients and hygiene is applied. In India, maybe
Yes,
hygiene is
yeah,
very good.
it's a,
Yeah,
but
but
yeah,
other countries,
in females it is always a channel, sir, especially
yeah.
in our country.
In obese females, it is a problem. In obese females, I see urinary tract infection, 1 in 15, genital infection, 1 in 15. We investigated urinary tract infection in EMPA-REG outcome, and especially in low EGFR below 60, we saw that a third of the people had urinary tract infection once during the study, but in the placebo group, the same. So if I have a urinary tract infection, I treat, or genital infection, I treat. Even if I have non, if I have
Mm.
bacterial colonization without symptoms, asymptomatic, I treat them. and I give an antibiotic if this occurs, and then I continue meanwhile. If it happens the second time, then I stop it. Yeah.
Sure, sir. Thank you. What about recurrent, UTI? So, when you stop, once again, when you start UTI, SGLT2 inhibitors, many of patients once again develop this recurrent infection.
Yeah.
So, how do you manage such cases, sir? Because, ultimately, it can be troublesome for the patients when you start SGLT2 and within couple of days they develop these problems.
Yeah, the anti-fungi creams, yeah, anti-candida creams are very effective.
Mm.
You prescribe them and you continue treatment. Yeah,
Okay.
when you have genital infections.
Mm.
However, some women, it's a nasty for some women. Yeah,
Mm.
it's irritating. They don't like it. So you have to really convince them. You continue,
Mm.
but sometimes if it comes the second time, then you cannot continue this treatment. Yeah, it's very rare, but it happens. I had this twice in the last years when I could not continue treatment because
Mm.
of recurrent genital infection. Meanwhile, in the renal life cycle trial, we have transplanted people. Among those, we have recruited 500 people after kidney transplantation. And it's not different. They are immunosuppressed, but they do not develop more infections. That's
Mm.
interesting. So it's something different. Yeah, it must be some genetics or another conditions which cause these infections. Thank you.
Yeah. So next is particularly related to a patient with the high glycemic load. So they have given a clinical scenario that maybe a patient with comorbid conditions and HbA1c level more than 8, would a combination of SGLT2 inhibitors with basal insulin would be a better choice there. How do you, tackle such case with the high level of glycemic load uh, in your patients with
It dep
comorbidities?
Yeah. So there are several conditions.
Mm.
If I have a very old patient, sometimes I tolerate hemoglobin A1C of 8 or 8.5 when the life expectancy is only 1 or 2 years.
Mm.
I hate hypoglycemic events. And if you have, depends also on the kidney function. If you have a very good kidney function, you can certainly go for insulin and SGLT2. But if you have a lower range of kidney function, then you should try to give them as much oral as possible because insulin causes later on hypoglycemic events, and this is more dangerous to the patient. I avoid sulfonylureas in low kidney function. We don't use them anymore, not necessary anymore. So it really depends on several conditions of the patient, on the age, on kidney function, and comorbidities, what I'm combine or what I'm using.
Sure, sir. So there is one next question is particularly related to the HFrEF patients. Sir. So what the doctor wants to ask is that after SGLT2 inhibitor, if still patient is diabetic patient with HFrEF, after SGLT2 inhibitors introduction, or maybe um, what would be the next choice of therapy to add in such kind of patients for additional glycemic control, sir?
For glycemic controls
Yeah,
in the HFrEF patient,
yeah.
after SGLT2, I use usually a DPP4 inhibitor
Okay, sir.
because it's still safe. Not the linagliptin has no problem virtually. We looked into
Mm,
details. Sitagliptin in the TECOS study had no signal, but vildagliptin or saxagliptin are
yeah.
not the preferred ones.
Mm. Sure, sir. Thank you, sir. Sir, one more question is particularly related to the safety aspects of SGLT2 inhibitor. Is there any increased risk of peripheral vascular disease with SGLT2 inhibitors? Is the question, sir.
We have now the meta-analysis. And after the initial canvas trial, all the other trials gave no signal for peripheral arterial disease.
Mhm.
The next trials excluded people with established PAD, so we thought we don't know it, but in the DAPA, CKD, and EMPA kidney, there was no exclusion of PAD people anymore, and we do not see a signal. And in the meta-analysis, it's a 6% increase, which still comes from the old canvas, but it's not significant. So we feel that bone problems or peripheral vascular problems are not important.
Thank you, sir. Thank you. So one more question we have received from the audience is particularly related to use of two drugs in combination. So DPP-4 plus SGLT2 inhibitor versus DPP-4 plus GLP-1 RA. So uh, I mean, what is your take there, sir? Is there any safety a risk, or what would be your preference depending upon the patient, sir? I mean, in which patient you would prefer DPP-4 plus SGLT2, and in which patient you would prefer DPP-4 plus GLP-1 RA? Um,
Yeah. So SGLT2 and GLP-1 or finerenone are very good combinations. I use them. However, it takes me a lot of time to include this in the patient. It's not so easy. One drug after the other in 2 month interval to get them into the patient. A lot of talking, convincing in the Western population. Yeah. The GLP-1s are have for 2 years not been available. The US has bought everything and we did not have any supply. Now we get for the diabetic people, we get GLP-1s back, and the endocrinologists using them very frequently because they also treat obesity with the GLP-1s. Yeah. In non-obese people, I did not use it a lot, and the FDA has given the label just 4 weeks ago for treating kidney disease with
yes, sir.
GLP-1. I do not use DPP-4 and GLP-1 very often because they are more or less superimposed in mechanism in part.
Yes, sir.
Yes.
Yeah. So the next question is, I mean, when we start SGLT2 inhibitors very early during the course of the disease, what are the benefits that we can expect in long-term management of diabetic patients in terms of, I mean, protection, kidney protection, heart protection, and also maybe other organ protection terms?
When you have a family with kidney disease,
Mm.
and we discuss all types of kidney diseases. Meanwhile, we think that when the family risk exists, we already start an SGLT2 inhibitors when the kidney function is normal. Yeah? When the kidney function is normal, but albuminuria is starting, then you have an indication because this is already diabetic kidney disease, and the albuminuria often goes away. So you have many, many years of albumin-free urine, and this is a sign of prevention. So we prevent progression of disease. So we can give them a certain time. However, I have seen also patients with, for example, IgA nephropathy, glomerulonephritis, non-diabetic kidney disease, where I had not of a lot of effect. Yeah. So it's not everybody is the same. So you just have to control them once per year. You do UACR or albuminuria test and EGFR in the early phases, and then you can see how the patient develops, weight is stabilized or increasing. So many factors impact. Actually, there is a certain protection, and you need to see this over time, over years. I have now done miracles in some people where I could absolutely stabilize the disease for now years. And I have a couple of others where I had absolutely no success, yeah, where disappointment is there. I think you are a doctor, you can feel when your patient is doing what you want, when he can afford it, and so many things are coming into place. Yeah. But the data overall, the data for protection are so good that you should try to bring people on as at least an SGLT2 inhibitor, whatever SGLT2.
Thank you, sir. Thank you. Sir, what is your opinion regarding use of SGLT2 inhibitors in post-MI patients, sir? So your take on that? I mean, there are studies, but most of the studies are neutral until now. Post-MI patients, sir.
Yeah, post MI, for example, NSTEMI, we have the example of the empiric outcome where cardiovascular death has been prevented. And we usually bring these patients on an SGLT2 inhibitor. And I think the data from empiric outcome are the best for preventing. Others are not so convincing.
Mhm.
I I'm looking now on the Impulse study, which is in-hospital SGLT2 inhibitors in acute decompensated heart failure after 42 hours. I think this study was positive. You reduce the de novo hospitalization by far, and directly post MI is not convincing. However, if you don't use it in hospital, that's my experience as a hospital doctor, the other doctors, the primary care and others, they would not use it. Therefore, I try to start it for diabetes and other complications, rehospitalization in hospital already, but not for especially treatment of acute MI. Yeah.
Thank you, sir. Sir, what is your experience, or what does the evidence say, particularly in terms of beneficial effect of SGLT2 in diabetic retinopathy, sir?
We have post hoc analysis in empiric outcome and other trials, and we did not see a lot of benefit. However, the methodology for really looking at retinopathy is a dedicated retinopathy study with not only slit lamp, but looking at the retina and the eye background, and we do not have this. So overall data so far are not convincing that we can influence this microvascular bed.
Okay, so thank you. So these couple of questions are from my end. I think we have still few more minutes. So if you are talking about CV risk reduction and organ protection, as per your experience among these three anti-diabetic medications, that is DPP4 inhibitors, SGLT2 inhibitors, and GLP-1 RA, how would you rate them, sir? Which would be your first preference, second, and third preference?
So, according to kidney function, my first preference always is SGLT2 anyway. Yeah, but
Yeah.
when you have low kidney function, you need directly another one. So I'm living in a country where I'm using GLP-1 next. But sometimes we can use in Germany only a certain amount per month of patients. Otherwise, we go over budget. So the government controls the budget. And if you prescribe it too often, then you cannot prescribe anymore. So then, of course, my second choice is a DPP4 inhibitor uh,
Mm.
because it's so well tolerated. You just give the drug, you don't have to explain anything. The patient is taking it, and he does not come back and with side effects. Therefore, also the GLP-1 receptor agonist is the better anti-diabetic medication. It's on the third place in my country. So first place SGLT2, then DPP4, and then GLP-1.
Thank you, sir. Thank you. There is one interesting question. Can we start SGLT2 inhibitors in case of SLE patient having significant proteinuria greater than 50, sir? So I think you would be the right person to answer that. SLE patient with significant proteinuria greater than 50.
SLE, so lupus, you mean?
Yes, sir. Yeah, lupus patients.
Um, Lupus patients have been excluded in the first trials. They were in EMPA kidney allowed. And when I'm giving, meanwhile, to stable lupus, not inflamed, not active lupus nephritis, stable lupus, then I see a reduction in albuminuria. In active lupus nephritis, I have not seen a lot of impact on nephroprotection. Maybe we do not have enough data. So I'm using it in chronic lupus with residual albuminuria without a big activity of the disease.
Thank you, sir. Maybe one last question, sir. I think we all know diabetes is a very progressive disease. So, do upfront use of this combination therapy, maybe, I mean, when he is diagnosed, combination therapy with two or three drugs, ultimately delay the need for insulin therapy later on, because we all know many of the patients end up needing insulin later on in their life. So, ultimately, does upfront use of combination therapy delay the need? And if it delays, I mean, in your experience, by what duration, sir?
Um, yes, it delays post hoc analysis, yeah, of all trials have shown less new patients on insulin during the trial period of 3 to 4 years, a certain percentage of less people. And so it delays, but I cannot tell you by how far. Yeah. And that's not, there are no solid data about this.
So thank you. I think we are dot on time. So I think we'll conclude today's discussion here. So on behalf of Intas Pharmaceutical, I'd like to thank our international faculty, Dr. Christoph Warner, sir, for joining us here today. It was indeed an enlightening presentation that we all enjoyed, and I think all the questions from the audience were addressed quite beautifully, and I hope all the audience are satisfied with the response. Last but not the least, I'd like to thank all the audience for joining us here today, this evening, and participating in wonderful discussion. Thank you, one and all. Good night.
Thank you. Thank
Thank
you.
you, sir. Thank you. Thank you, sir. Thank you so much, sir. Is the relay